what are all included in this acute aortic syndromes? You have aortic rupture, okay, aortic dissection, you have IMH, which is nothing but intramural hematoma, and finally PUA, which is nothing but penetrating atherosclerotic ulcer. We'll see them one by one. Okay, so this is the longitudinal and the cross section of a normal aorta. Okay, so what you find is all three layers of the blood vessel. You have intima, media, adventitia, and this is the lumen of the aorta. So this is absolutely normal aorta. What you find here is the intimal tear. Okay, so there is intimal flap here. The intima is disrupted, and then blood flows into it, creating a false lumen, and then there is a true lumen. Sometimes the false lumen is so big, the true lumen gets squashed up. Okay, so this is classic aortic dissection. Okay, so the C image is called IMH. That is called intramural hematoma. Here, if you see, the intima is intact. So, but still there is collection of blood in the media. Why is this happening? So this is because of rupture of vasa vasorum. Rupture of vasa vasorum with hemorrhage into the wall of aorta. Here the intima is intact. So this is IMH. This IMH can progress to dissection or rupture. So that's why we are worried. So this can break the intima and then cause dissection. So this can progress downwards, upwards. So this can give away on the other side, causing rupture. Okay, so that's why we are worried about this IMH. Okay, so the final one is PAU, penetrating aortic ulcer. Okay, penetrating aortic ulcer. Here you have an atherosclerotic block which ulcerates and penetrates into the media. Okay, the internal elastic lamina is broken, and then the ulcer penetrates into the media. So this is called penetrating atherosclerotic ulcer, and it is a localized disease. It's a localized disease. Okay, I'll show you images of IMH and penetrating ulcer just for understanding. Okay, so this is a coronal CT without contrast. See, you see, this is aorta, and this white arrows, this linear streak, it's linear streak. So this is there. This tells you that there is high attenuation in the aortic wall. You don't know what it is. You give contrast. What you can see is the lumen of the aorta is filled by the contrast beautifully, and outside the lumen you find this darkish areas, which is marked by the asterisks. So this is the aortic, entire aorta. Okay, but this is only the lumen. The lumen is compressed, and there is something which is dark in color outside the lumen. Okay, so that is IMH. That is IMH. So this is the pathological specimen. Can you see? So this is the aorta, and this is the lumen of the aorta, and what you see here is the clot in the vessel wall. Okay, clot in the vessel wall. So this is IMH. So this image tells you that there is a tear. That's a tear in the aortic wall. Okay, there is a longitudinal tear in the aortic wall. Okay. So this is PAU, penetrating atherosclerotic ulcer. So you see like a nipple-like projection here, no? See like a nipple-like projection. So this is that penetrating atherosclerotic ulcer. Okay, aortic ulcer. So this was from a patient who came in 2014, asymptomatic. In 2016, he presented with acute aortic syndrome, where if you can see this outside this aorta, there is this black portion which is increased. So this is predominantly IMH with hemorrhage, or because of this PAU, penetrating atherosclerotic ulcer. Okay, so the C image, so this is post repair. They have put a stent graft. So this white interrupted lines, so this is the stent. So because you have stented this, we have put a stent graft. So this is reduced in size, and this is thrombostop. Okay, so this is the treatment. This is what we do in endovascular repair. And this is a pathological specimen, a pathology specimen taken from autopsy patient, where you see this is the stent graft. You can see, no, this is the stent graft which has closed this thrombosed penetrating atherosclerotic ulcer. Okay, thrombosed atherosclerotic ulcer. So how do you classify dissections? Okay, so the most commonly used two classifications are Stanford classification and Debeke classification. Okay, so this is more simple. It has only two classifications, A and B. A stands for ascending, so it does not bother about where the intima is, distally where it extends, nothing. If you have ascending aortic involvement, it is called type A. Very as simple as that. If ascending aorta is involved, it is called type A. Okay. Type B is ascending is not involved. Arch may also be involved, but definitely ascending aorta is not involved. So that is type B. So as simple as that. That is Stanford. DBK has three types. Okay. Type 1, type 2 and type 3. So what is type 1? Type 1 is starting from the ascending. So this is based on the site of tear and extent. Okay. So type 1 is starting from the ascending till the descending aorta. Okay. So from the ascending it progresses to the arch and then the descending aorta is also involved. So that is type 1. Type 2 is only ascending and arch. Here DTA is not involved. Type 2. Okay. Type 3 is only descending thoracic aorta. Only descending thoracic aorta. Okay, I'll show you an image. So this is DPK type 1. I told it starts from the ascending and extends till the descending. Okay. Type 2 was only the ascending. Okay. And sometimes arch can be involved, but definitely not descending. Definitely not descending. Type 3 is descending. Okay. DTA is involved. Based on the extent, it is divided into 3A and 3B. So supra-diaphragmatic is 3A, infra-diaphragmatic is 3B, nothing else. Okay. Stanford type A, I told you, whenever ascending is involved, it is type A. Whenever ascending is not involved, then it is type B. Clear, guys? Clear? Very simple, no? Two classifications. So then based on the duration, they are also classified as hyperacute, acute, subacute and chronic. Okay. Less than 24 hours is called hyperacute. (24 to 14 days is called acute. 14 days, this is 24 hours. 24 hours. 14 days to 90 days is called subacute. And anything more than 90 days is called chronic. So this is based on timing. Okay. And the frequency of aortic syndrome, predominantly type 1 or ascending aorta involvement is seen in 60%. Okay. 10 to 15% can have extensive. Okay. 10 to 15% can have type 2, which involves ascending and arch. Okay. Type 3 accounts for 25 to 30%. Type 3 accounts for 25 to 30%. Clear, guys? So I told you it's an acute aortic syndrome. So acute aortic syndrome, they are usually present acutely. Patient, how do they come to you? They come to you with a sudden chest pain. Sudden onset chest pain. Okay, most often confused with acute coronary syndrome. Okay, you see patient is jumping on the bed with chest pain, back pain. Okay, you see BP sky high, 200, 100, ECG, there's no change at all. Troponin, some mild elevation. Okay, echocardiogram you do, there are no regional wall motion abnormalities. LV is absolutely fine. So you're confused. But if you just put the probe one intercostal space above and then see the aorta, sometimes you can see a flap. So this can be an acute aortic dissection. Do not miss acute aortic dissections. Sometimes even acute aortic dissection can present to the inferior wall MI, because the dissection flap can go and close the right coronary ostia. So this can present to you with an inferior wall MI. Always in hypertensive patients, okay, when they present to you with acute onset chest pain, please remember to check pulse and BP in all 4 limbs. So you're not sure of the diagnosis, always put a probe and see, or do a CT aortogram to make sure that there is no dissection. Okay. So they present to you with sudden onset severe chest pain, which is tearing in quality. Tearing in quality. Okay. So this is associated with diaphoresis. Okay. They can also have syncope. They can also have dyspnea. Okay. On examination, what you find is both extremes can be there. You can also see hypertension. You can also see hypotension. They can also present to you with shock. Okay. So it is always important to check for pulses in all four limbs. Okay. Check for pulses in all four limbs. Okay. So they can present to you with an acute AR also, pulmonary edema. You can see them with stroke, hemiplegia, paraplegia, spinal cord ischemia can be there. Okay. Spinal cord ischemia can be there. So all these are malperfusion syndromes. Okay. You can have spinal cord ischemia, you can have paraplegia. Okay. Bowel ischemia because of occlusion of bowel vessels. SMA can get occluded if they are all arising from the false lumen. SMA, celiac, IMA can get occluded. Okay, I told you because of the dissection flap closing on the RC ostia, you can have myocardial infarction also, inferior wall hemorrhage. Okay, if it retrogradely dissects and extends, you can also have hemopericardium, cardiac tamponade. So all these are possible. So it has a wide spectrum of presentation. Okay, so you should be really sharp to pick up the diagnosis. So this is a slide which tells you the complications of aortic dissection and the mortality associated with this complication. This is in-hospital mortality. If a patient presents to you with hypotension or shock, cardiogenic shock, it can be hypovolemic shock, the mortality is approximately 60%. Okay, mortality is approximately, even if you do something, you don't do something, the mortality is somewhere around 60%. Okay, if you don't do something, sorry. If you do something, obviously you can salvage the patient. But even then, the operative mortality is higher, 25%, but still much lower than the non-operative mortality. Okay. So cardiogenic shock can be because of tamponade, I told you, because of acute AR or because of coronary osteocclusion. Okay, hypovolemic shock is because of aortic rupture. Okay, sometimes you can have this branch vessel involvement. Aortic branches can get involved. See the bowel ischemia because of occlusion of SMA, IMA, celiac. You can have severe lactic acidosis. Okay, because of occlusion of the carotids, you can have hemiplegia, strokes. Because of spinal ischemia, you can have paraplegia. Okay, because of renal artery occlusion, you can have acute kidney injuries. So all these are a part of branch vessel involvement. Whenever you have branch vessel involvement, the mortality is somewhere around 30%. Okay, when you have an hematoma around the aorta, periaortic hematoma, the mortality is around 11%. And none of these features are there, even then the aortic dissection can have a 4.4% in hospital mortality. 4.4% in hospital mortality. So how do you manage this acute aortic syndromes? Okay, the first is aggressive medical therapy. What do? You control the rate, you control the pressure. Okay, so you give intravenous labetalol, okay, which is a combined alpha and beta blocker, or a short acting beta blocker. If there's no contraindication to beta blocker, if the patient is not in hypotension, okay, then you can give intravenous labetalol or esmolol, or you can give in even CCBs like verapamil, diltiazem. So this to control the blood pressure and then to control the heart rate. Okay, so heart rate target is around less than 60. Blood pressure target is to bring it below 128. Okay. So for pain control, you give intravenous opioids. We give morphine here, so that also reduces the blood pressure, so that also alleviates pain, which is very useful. Okay. If despite this, if the BP is more than 120, you can add vasodilators like nitroprusside or angiotensin converting enzyme inhibitors. Okay. The goal is to keep the BP as low as possible and maintain adequate organ perfusion. So that's a class 1 indication. Okay. Plain vasodilators like hydralazine is contraindicated because it increases the hydraulic stress and it can propagate the dissection. You give either labetalol or esmolol, or you give sodium nitroprusside. Okay. So this is the first step. Okay. So if you have done a contrast CT and then you have diagnosed a dissection, based on which type of dissection the management changes. If it is type A dissection, then you refer for open surgery. Okay. So type A dissections cannot be treated percutaneously. Okay. Type B dissection, and if it has any one of the high risk features or any one of the complications like organ malperfusion, or if there is extensive dissection, or if there is refractory hypertension, or the pain is refractory, okay, then if you have a favorable anatomy, then endovascular repair is what is favorable anatomy. You should have a good landing zones. Okay, so you should have a 5 mm seal proximally and then distally at least 5 to 10. So depending on the centers, at least 5. So at least 5 cm seal you should have. Okay, otherwise it can progress retrogradely. Even your stent graft can enable the progression to proximally and then propagate the dissection. Okay, so that's why we say it is a favorable TVAR anatomy. If it is favorable, then you send them for endovascular repair. If it is unfavorable, then open surgical repair. So if you have complication, then definitely intervention is required. Uncomplicated. So even in uncomplicated, if you have high risk features, then it is a class 2A indication for intervention. What are the high risk features? At your level, it may not be needed. So when the diameter is more than 40 mm, or if the entry tear is more than 10 mm, or if the total aortic diameter is more than 5 mm, or if there is a hemorrhagic pleural effusion, or if there is malperfusion evidence or reappearance of pain, all these are taken as high risk features. Okay. So then you consider endovascular repair. So we'll see a case here. A 58-year-old gentleman, known hypertensive and smoker, presented to the ER with a history of sudden onset lower abdominal pain and back pain for the past 2 weeks. On examination, his blood pressure is 180 over 94 millimeters. He is tachycardic with a pulse rate of 116. Systemic examination is unremarkable. How will you proceed? So, couple of things here. One, you should have given abdominal palpation findings. They have given systemic examination is unremarkable. So I think we'll take it as normal. Okay. Second, I told you should examine pulses in all 4 limbs. So that will give you a very important clue. You never know. So this is a very vague pain, but it is one thing is it is very sudden onset. And he has 2 important risk factors for atherosclerosis and dissection. Hypertension, he is a smoker also. Okay. So never miss dissections in these patients. Okay. Always examine pulses in all 4 limbs. Measure BP in all 4 limbs. So this is actually a very, this is a real case from our hospital. Okay. So I'll show you a CT scan. They did echocardiogram. They said there's no dissection, but he kept on saying severe abdominal pain. They did amylase, lipase, pancreatitis was ruled out. Then they did ultrasound abdomen. Ultrasound abdomen, they said no hemorrhagic effusion, no ascites, there's no abscesses in the liver, spleen. Okay, but apparently they missed to see vascular ultrasound. You need to pay attention, otherwise you will miss it. Okay, then this CT was done. So this is the aortogram at the level of renal artery. So if you can see closely here, I think this is a video, I can play it too. Okay, let's cover it. So if you look closely, this is the aorta. Okay, this is the aorta. So what you find here is like a division, no? One black line between cutting through the aorta. Okay, so that is the dissection flap. Okay, so this is seen in the abdominal aorta. Okay, if you are not very careful, you will definitely miss that. So that is the dissection flap in the abdominal aorta. So this is what I'm saying. So this is the dissection flap in the abdominal aorta. Okay. So if you trace the same CT above, what you can see is a very well lit up aorta with contrast, and around the aorta you find this one. Okay. So this is not normally seen, no. So on the wall of the aorta. So this is IMH. This is IMH, intramural hematoma. Okay. So we proceeded to do a aortogram for this guy, and this was the aortogram. Okay. So we take femoral arterial puncture and then pass wire, and then through the wire take this pigtail catheter. So pigtail catheter will be like this. Yeah. Pigtail catheter. It will have multiple holes. It will have 6 side holes. This is not needed for you. 6 side holes and 1 end hole. Okay. Totally 7 holes it has got. Okay. So this is to give more volume of the dye to look better. Okay. Nothing else. Okay, so this is the aortogram. So what you see in the ascending aorta and DTA, okay. So if you can see this ascending aorta is maybe some mildly dilated, you'll have to measure, but the descending aorta is definitely looking smaller. Okay, if you had not done the CT, you would have definitely missed the IMH here. Okay, intramural hematoma is not seen in the luminal aortogram, because you are injecting dye into the lumen of the aorta. Here the lumen of aorta is absolutely normal. What you find is on the outer surface of the aorta. Okay, so on the CT we saw that IMH, okay, in the descending thoracic aorta. Okay, and this is the abdominal aortogram. So this is in fact after a procedure. What you can see here is a stent graft. So leave that. But in the abdominal aortogram, what you see here is a dissection flap. So you can see here, no? So that's the dissection flap. Okay. So I'll play it for you again. So this is the dissection flap, and you can see it. This is the false lumen. So that is less brighter than the true lumen, and it lights up very late after opacification of the normal aorta. So this is the dissection flap, and then what you are seeing is the false lumen. Okay. So ideally what you will have to do, you will have to close this dissection flap. Either you will have to do it open surgically, put a graft inside, or interposition graft, or do it with a stent graft. Okay. So the problem here is the IMH is there in the descending thoracic aorta. You just go put in a graft here, then this IMH may progress. It can cause dissection, it can cause rupture. So you'll have to repair even that. So if you trace the CT shows IMH even till the left subclavian artery. Okay. So what we do is we do zone 0 repair, meaning so if you don't have a landing zone, or if you think the dissection or the IMH can progress retrogradely, we go till the sinotubular junction and then repair. Okay. The first stage of this procedure we did from zone 0 repair, we covered till the DTA. The second stage we covered the abdominal aorta, and this is the final repair for this patient. Okay, what we use here is a endograft. Okay, endografts are covered stents, meaning you put it inside, it will knock off all the branches. Then how do you stent the aortic arch? So what we do is we make fenestrations. in the endograft. Okay, so like this, if you see, you have fenestrations that are made by the physician. So it's called physician modified endograft. It's called PIG. Okay, physician modified endografts. You make fenestrations, and through the fenestrations you put a stent, so that through the fenestrations you put a stent, so that this branches remain open. So the same way you can do it for the abdominal aorta also, for the renals, for the celiac, for the SMA, you will have to do the same fenestrations. Only DTA doesn't have any major branches, you can just put a graft like that. Okay, so this was done in two stages. The first stage where you put a zone 0 repair starting from the ascending till the DTA, and in the second stage we put grafts till the aortoiliac bifurcation. Okay, till there the graft was full. Okay.